Welcome to the Animal Heartbeat, the only dedicated podcast for enthusiasts of veterinary cardiology. As far as we know, maybe there are some rival out there, but we're definitely the premier podcast for people interested in veterinary cardiology. My name is Kieran and I'm here today with my co-host and general cardiology buddy, Jose Novo Matos. We are here to talk to you about pulmonary hypertension. Any of you who know a little bit about cardiology may have encountered pulmonary hypertension patients, whether you know about it or not. Jose, is pulmonary hypertension our friend to diagnose, or is it our foe? Is it a big complication we need to worry about for our patients?
Tony Glaus used to say it's like anemia. You diagnose anemia, and then you need to find causes for anemia. And I think it's a good analogy. So I think it's an exciting condition. Because our echo will give us a lot of information about it. It's not that difficult to diagnose pulmonary hypertension, but then to find the cause, I generally think if you don't find the cause in the first 45 minutes, then you will not find the cause, or it's going to be really tough to find the cause.
I agree with what you said about it being a challenging diagnosis, but I also think it's quite a rewarding diagnosis as well. One of my favorite situations is these patients that have got increased respiratory effort, and we believe that we've treated their pulmonary edema, their left-sided heart disease, as best we can. And then we diagnose pulmonary hypertension, and actually suddenly we can massively improve their welfare by treating the pulmonary hypertension. I think that could be really rewarding. I think we're getting ahead of ourselves. The important thing to remember about pulmonary hypertension, as you say, it's a bit like anemia. It's a secondary disease rather than a primary causative diagnosis in the vast majority of cases. Let's think about the typical presenting signs for pulmonary hypertension.
Precisely.
When would you suspect pulmonary hypertension in your consulting room?
That's a really important starting point, also for general practitioners and so on. So I think the classic clinical signs or presentation where we would have pulmonary hypertension on our top differential diagnosis list or top 3 will be patients presented with collapse and right-sided congestive heart failure. So a patient that presents with collapse, syncope, and or ascites, pulmonary hypertension needs to be high on our list. And then there are other less specific clinical signs: exercise intolerance, tachypnea, dyspnea, stress, which of course may be caused by primary lung disease or heart failure.
Sometimes just the nature of the respiratory pattern and the history around that respiratory pattern, if you interrogate that a bit more, can be quite suggestive. So where pulmonary edema tends to cause these sort of rapid, shallow breathing patterns, or restrictive, if some people use that term, and the same type of breathing pattern you see in pleural fluid, I think with pulmonary hypertension, it's much more mixed. It almost looks like there's an expiratory push, like an obstructive push in these patients. And often the rate is not so high, but the effort is increased, even at rest. And that's quite a big flag for me. And it's much, much worse after exercise. And there may or may not be syncope. That would be a classic patient, even in the absence of right-sided heart failure signs for me, where I'd have it as a big differential.
This brings us to the causes then, because there will be a big difference if we think about the mitral valve disease dog as a classic example versus a dog with pulmonary fibrosis. So talking about causes, so there are some very nice and recent ACVM guidelines on the diagnosis, treatment, and management of pulmonary hypertension in dogs. And then the expert panel did an amazing job. The guidelines are very thorough, very well written.
They're great, aren't they?
Indeed, great, yeah, and very user-friendly. So we would recommend everyone to look at them. Again,
they are available open access on the Journal of Veterinary Internal Medicine website.
Exactly. Causes of pulmonary hypertension are divided in 5 or 6 classes or groups. So group 1 will be pulmonary arterial hypertension. An example would be a left to right shunt. So the problem is in the pulmonary arteries. Group 2 is pulmonary hypertension secondary to left heart disease.
And this is the big one for us, isn't it?
A huge one, exactly.
Huge, yeah.
Group 3, pulmonary hypertension secondary to chronic lung disease or lung disease and or hypoxia. Group 4, pulmonary thromboembolism. Group 5, which is the new class in comparison with humans, is parasitic disease, which is again a very important group. This means Dirofilaria and or Angiostrachus vasorum. And finally, group 6. Group 6 may be caused by different mechanisms. Classic example, Dirophyllarimetis, which may cause pulmonary thromboembolic events. When the worms died, causes vasculitis, so it affects the pulmonary arteries. May also cause parenchymal disease. So have different mechanisms. So this is group 6 with clinical presentation, as we were saying. The mitral valve disease case, to me, I totally agree with you, the respiratory pattern and so on, and that's important. But the mitral valve disease, to me, the classic huge red flag would be a dog that has ongoing mitral valve disease, or let's say is the classic breed, signalement for mitral valve disease, and has ascites, or suddenly develop ascites when it has.
So we know they've got left-sided heart disease. It's been going on for a while, whether that's because there's been an actual echocardiographic diagnosis or radiographic diagnosis, or just a very long-standing murmur that localizes on the left. And then the dog's now in right-sided heart failure. The key rule out for me there would be atrial fibrillation.
Precisely, exactly. Dogs that develop pulmonary hypertension secondary to left heart disease must have severe left hearted changes. By this, I mean they will have big left atriums on echo. There's maybe one exception or two, but as a rule, they need to have significant left-sided disease to have secondary pulmonary hypertension.
I think if you've got a dog that you suspect of having pulmonary hypertension and you look at the left heart and it's normal or is not enlarged, maybe there's a little mitral regurg, but there's no left atrial dilation, I think you can rule out class 2 pulmonary hypertension.
Exactly. So how do we diagnose pulmonary hypertension? Everyone knows we need an echo, but then what's your approach when you start scanning these patients? How do you go ahead and diagnose pulmonary hypertension or suspicion of pulmonary hypertension?
I think the first thing is I have a look at the right heart and make a subjective assessment of the right heart compared to the left. It's a little challenging because if it is a dog with pulmonary hypertension secondary to severe left heart disease, which most of our patients are, well, they've got a big left heart. So, of course, your subjective comparison is always a little bit unreliable. But I guess if you have got a big left heart and the right heart is 75% the size of the left or the same size as the left, then it's definitely abnormal. We would normally expect the right side of the heart to be about 1/3 to 1/2 the size of the left, just subjectively. I'm talking about atrium and ventricles. So for me, if it looks like the right heart is subjectively large, or it looks like the right heart is subjectively hypofunctional, then that might suggest to me that there's some pulmonary hypertension. If it's acute, the right heart tends to look much less functional than one would expect. And if it's chronic, often the function can subjectively look normal. The size of the pulmonary artery is important. And if the pulmonary artery is more than 1.3 times the size of the aorta, then that would suggest to me that the pulmonary artery is significantly enlarged. So those are things that are important for me in the absence of any fancy Doppler measurements. That's just a subjective assessment. We can measure the right ventricular wall thickness, and we can measure the right atrial size and compare those to allometrically scaled, body size scaled reference intervals. I don't tend to do that routinely, I have to say. I use a subjective assessment.
Just to remind everyone, so pulmonary hypertension will cause increased afterload to the right ventricle. So it's a pressure overload state. What is funny is about the right ventricle. The right ventricle is a volume chamber. So it doesn't behave really well with pressure. And so we will not see the classic severe RVH as you see with outflow tract obstruction with pulmonary valve stenosis. So there will be a mixed component of eccentric and concentric hypertrophy. But the big right heart, as Kieran was saying, I think IVS flattening, I like also to look at the septum to see if
good point.
Short axis. Because if the septum is flattened, that means that the right ventricular pressure is higher, is suprasystemic, is higher than the left ventricular pressure, and that's a sign
sometimes you have abnormal septal motion when it's
exactly,
don't you? This sort of right-sided deviation in early systole or paradoxical septal motion.
Yeah, and all that stuff would then guide you to say, okay, there is increased right side, there is right ventricular pressure overload. Of course, one needs to exclude outflow tract obstruction. So we need to be sure that pulmonary artery is patent. There is no pulmonary valvular stenosis. There is no abnormality obstructing any changes obstructing the RVOT. And so those are the first signs that should trigger one should think, okay, pulmonary hypertension. Unfortunately, on clinical practice, we will not measure right heart. We will not make a right heart catheterization and pulmonary artery wedge pressure and so on to measure invasive pressures. So in veterinary medicine, we don't do that, right?
And we wouldn't see these cases where we think, oh, there's pulmonary hypertension. Let's measure directly the pulmonary pressure, we would all reach for a non-invasive method like echo. We have to use these sort of secondary indicators.
Very challenging though, isn't it? Because sometimes some of these guys have received furosemide, and then you may not really, and then that decrease already the pressure. You need to.
And in humans, they'll just do it bedside, won't they? Yeah. They'll just, they'll say, "I'll just sit still. We'll just, sharp scratch. We'll put a catheter in your pulmonary artery." Yeah. And we have to anesthetize our patients. And of course, depending on what the agents are that have been used, there are some real challenges in our diagnostics in animals or in our invasive diagnostics in animals compared to people. So therefore, we definitely rely much more on echo for these cases. So I think historically, veterinary cardiologists have focused on tricuspid regurgitation velocity for the diagnosis of pulmonary hypertension on echo. Years ago, I think I would look at the right ventricle subjectively, but I would really focus on TR velocity. The theory behind this is that your tricuspid regurgitation velocity tells you the pressure difference between the right ventricle and the right atrium in systole, because that's the way the flow is going from ventricle to atrium retrograde through the tricuspid valve in systole. And in systole, the pulmonary valve is open. So therefore, the right ventricular pressure in systole is equal to the pulmonary artery pressure in systole. So therefore, if the right ventricular pressure is increased in systole, and there's no outflow tract obstruction like a pulmonic stenosis or whatever, then there must be pulmonary hypertension. So historically, we've looked at these dogs and said, well, if the tricuspid regurgitation velocity is more than 2.8 meters per second, that suggests pulmonary hypertension. The recent consensus statement in 2020 suggests 3 meters per second is a cutoff. And actually, they go even higher with their cutoff for a sort of slam dunk diagnosis of pulmonary hypertension. And they say greater than 3.4 meters per second is suggestive or strongly suggestive of high probability of pulmonary hypertension.
They talk about probabilities, and I think that's very cool.
They do talk about probabilities, yeah.
Probability of diagnosis. And I think that's very cool, because then is, again, as we discussed, with feline cardiomyopathies. I just wanted to talk about
the drinking game. Everyone should drink now, because Jose's talked about feline heart disease.
It's just that it's a puzzle, and it's not one echo variable will not give you the diagnosis. I think it's really cool that they talk about probability of pulmonary hypertension.
Yeah, and I think that's changed how we talk about it, because we used to say this dog has pulmonary hypertension with a TR velocity of 4 meters per second. And I think what we should say now is, in all likelihood, this dog has got pulmonary hypertension, or there is a high probability of pulmonary hypertension. You've got to judge that in context. If you've got, a TR velocity of 5, so you're from that, we're saying the right ventricular pressure, that the pulmonary artery pressure in systole is 100 meters per second. 100 millimeters of mercury. That's so high, I would expect secondary 2D changes. So therefore, look at the right heart. Is there a sort of combination of dilation and hypertrophy? Are there functional abnormalities? Is the right atrium dilated? What's the caudal vena cava doing? I love looking at the caudal vena cava. One of my residents taught me this a couple of years ago. I'd never done it. And he said, "Oh, don't you look at the caudal vena cava routinely?" I always do. Well, yeah, okay, I do now. Iñaki trained me in finding the caudal cava and assessing it. I look at it in every patient now and look at the hepatic veins. So if there's hepatic venous distension, just subjectively, if the caudal vena cava does not collapse on inspiration, that tells you the right heart pressures are high. Even in the absence of ascites or hepatomegaly, those vascular changes can be quite sensitive changes that help you identify a high risk of right-sided heart failure or increased risk of congestion on the right side. So I think if you combine that with your tricuspid regurgitation, with your 2D changes on the echo, that's really important. And looking at the consensus statement, they say that even if you've got no tricuspid regurgitation, but you have got a big right atrium, a big right ventricle, and potentially caval dilation and hepatic venous changes and a big pulmonary artery, but it doesn't matter if you haven't got tricuspid regurgitation, you can still say there's a high probability of pulmonary hypertension in that patient.
Yeah. And that's a good point, because several dogs will not have tricuspid regurg, or the tricuspid regurg will be very small, very eccentric, and then, as always, Doppler will not be able to align your Doppler properly, and then Doppler assessment will underestimate pulmonary arterial pressure. We have also started doing a pulmonary artery distensibility index, and it's the same idea, that to have further assessments, echocardiographic assessments of potential pulmonary hypertension. And so by that, we mean that the right pulmonary artery, you may assess how much the right pulmonary artery distends between systole and diastole. And I believe should be more than 30%. I believe
That's correct. Yeah, 0.3.
Right?
Yeah.
And so it's also another 2D assessment to diagnose pulmonary hypertension. And again, as we mentioned, and I'll repeat, what is neat about the guidelines is that they try to put that together. The guidelines have focus less on pulmonary regurgitation velocities, understandably, right, because as you were saying, historically, we have all focused on TR. So we would still look carefully at PR, because in case that do not have PR then can give you that extra confidence on diagnosing pulmonary hypertension.
I do think it's a bit more of a mixed bag, isn't it? The pulmonic regurgitation velocity, like how reliable it is. And I think one particular time when it's not reliable is actually pulmonic stenosis. When, of course, with pulmonic stenosis, we can't assess tricuspid regurgitation velocity reliably because that tells you about right ventricular pressure. And in pulmonic stenosis, the stenotic valve means your right ventricular systolic pressure is not the same as your pulmonary artery systolic pressure. So therefore, we can't use TR. We can't use right heart changes because of pressure overload and ongoing right ventricular hyperplasia because of that neonatal pressure overload. So some people... some cardiologists, I think, look at pulmonary regurgitation velocity and say, oh, it measures, 2.73 meters per second. This is too fast. Therefore, the dog must have pulmonary hypertension. I would disagree, because I think with the modified Bernoulli equation, which we use to calculate those pressure gradients, it relies on us knowing what the pressure is and what the fluid dynamics are in at least one of those two chambers. And I think when you've got a big post-stenotic dilation or some sort of abnormality of the tunnel of the valve, I just don't buy that we can say those dogs have pulmonary hypertension with pulmonic stenosis. What are your thoughts on that? Because I know it's a bit controversial.
Yeah, no, I agree. And it's always, I think it's always interesting and raises always a lot of questions when we see those cases with severe pulmonary stenosis, and then, as you were saying, exactly as you were saying, a peak TR of 2.5. To 6.3. We then measure invasive pressures while we are, of course, doing balloon valvuloplasty and generally do not document diastolic pulmonary hypertension.
Sure.
So I agree with you. One needs to be careful because as you were saying, is the modified Bernoulli equation. The Bernoulli equation includes a lot of different factors that we completely ignore in standard situations, which cannot be ignored on that scenario. And the same with severe tricuspid dysplasia is the other example. I think severe tricuspid dysplasia, a lot like torrential tricuspid regurg and so on. Sometimes the peak velocities are high. And it's not that they have pulmonary hypertension, most likely. So I agree with you. I think it's always an interesting finding, and then we are extra careful when we assess invasive pulmonary arterial pressures before and after ballooning to see what is happening.
And one of the things that we know with pulmonary hypertension is that the pulmonary vasculature does not like increased flow, either on the venous side or on the arterial side. And this, we think, is the pathophysiology of class 1 and class 2 pulmonary hypertension. So class 2 being the secondary to left-sided heart disease. If you have increased venous pressures chronically, then you get some remodeling and some vasoconstriction of the pulmonary arteries because of the nature of the physiology of the pulmonary vessels. And when you have an increase in arterial flow, like a PDA or a big VSD or something, I always think of it as the pulmonary arteries are trying to protect the pulmonary capillaries from that increased flow. So they vasoconstrict to reduce the likelihood of that increased flow causing pulmonary edema. But because of the vasoconstriction, they end up with pulmonary hypertension. And longer term, that can cause secondary changes that's irreversible. So I think because of the pulmonary vasculature being quite sensitive, it's got a high tolerance for increased flow at exercise, but these pathological causes of increased flow, it doesn't like them at all. And because of that vasoconstriction, we end up in this situation with class 1 and class 2 cases. Explain for us the pathophysiology of class 3 pulmonary hypertension, just touching on that, the secondary to respiratory disease.
Yeah, I just thought just also... I like, so we can classify pulmonary hypertension in these 6 groups, as we have just mentioned. Another option is to classify pulmonary hypertension as pre-capillary and post-capillary. And I like that.
Right.
It works well for me in my brain to think about post-capillary and pre-capillary. Post-capillary will be pulmonary venous hypertension. So pulmonary hypertension caused by left heart disease, myxomatous mitral valve disease being the classic example. And then anything that affects the pulmonary arteries will be precapillary. I like this also to discuss differential diagnosis when we discuss with the residents, to split the cause as pre and post capillary. But as you were saying, then of course, long-standing post capillary may also have pre-capillary changes. So regarding class 3, it's very cool. And again, we could spend a lot of time here, but so class 3 is hypoxia or primary pulmonary disease as a cause of pulmonary hypertension. And this is a big group because, of course, we maybe talk about parenchymal disease. The classic example, poster child. I learned this with you, poster child. And poster child of pulmonary hypertension, class 3 will be pulmonary fibrosis, the Westie with pulmonary fibrosis. So classic class 3. But then this is a big group, and so any cause of hypoxia or abnormalities in the airways, if you want to talk of tracheal collapse, bronchial collapse caused by bronchomalacia, all this stuff will be class 3. As you were saying, the pulmonary arteries will try to protect the capillaries. I like that idea, and so hypoxia will cause pulmonary artery vasoconstriction. Class 3 maybe because, again, just to summarize, because the parenchymal is completed, there is severe parenchymal disease and the pulmonary parenchyma is destroyed, and so the pulmonary pressure will increase, maybe caused by airway abnormalities, obstruction, physical obstructions, collapse, or maybe caused by hypoxia. High altitude disease, high altitude pulmonary edema, big thing in humans, is
big
caused
thing
by
in cows.
altitude
Disease. Cows don't like being high up. And there are some big species differences in pulmonary vasculature, which is super interesting.
And how they respond to hypoxia, precisely. And so hypoxia may cause vasoconstriction. And that's an important take-home message, because in case when you are assessing pulmonary hypertension, you need to consider if the patient is in oxygen. This will affect your assessment. Hypoxia, a patient with severe pulmonary edema, and we see that. And then when we treat the pulmonary edema, the pulmonary pressure improves. This may be, of course, because you unload the left atrium, but may also be caused by hypoxia. So exactly, so hypoxia, severe pulmonary disease may cause pulmonary hypertension. And that's where my frustration starts with pulmonary hypertension. So I'm very happy and excited.
We're all right with the cardiac stuff,
exactly.
But the respiratory stuff.
And even let's say then is a patient with immune-mediated hemolytic anemia. I think even the class 4 pulmonary thromboembolism, I'm not so unhappy. If then we find a systemic disease that may prone the patient to be prothrombotic,
right.
And so classic examples: immune-mediated hemolytic anemia, a patient with hyperadrenal corticism, protein-losing nephropathy, protein-losing enteropathy.
Yeah.
Neoplasia, pancreatitis, bad pancreatitis, and then say
any big inflammatory disease, right?
Exactly.
Or neoplastic disease.
Exactly.
It could be a trigger.
Yeah, and then at least if we identify a prothrombotic state condition, we at least we suspect, and we can try then to anticoagulate these patients. We can discuss that later. Is when we have primary suspicion of primary lung disease that the diagnosis, with the exception of the classic Westie, we are between a rock and a hard place, because we will need X-rays are terrible to assess interstitial lung disease.
Oh, right. And CT as well, actually. Yeah. People are very excited about CT. And I remember I had one where the imagers said to me, no, there's absolutely no fibrosis in this dog. This was a dog with terrible left-sided heart disease. So he became tachypneic. We thought he'd gone into left-sided failure. So we started furosemide, didn't get any better. And then we increased his furosemide dose, didn't get any better. Really, quality of life was becoming an issue. We didn't really want to anesthetize him because he had pulmonary hypertension. So we started sildenafil. Sorry, I missed that step. Crucial step. Started sildenafil treatment. Didn't get any better. A little bit, not much. And his respiratory effort got worse and worse. And it wasn't a classic pulmonary edema. We treated with antibiotics. I know it's a bad thing, but we decided we'd treat him with amoxicillin clavulanic acid because we thought, okay, well, what's treatable? Infection. So in case he had an interstitial pneumonia. Now, I've seen cases with interstitial pneumonia and pulmonary edema, and they get better on antibiotics, and fantastic. He didn't do that. Got worse and worse and worse. Sadly, he was put to sleep. I said to the owner, look, I don't understand what happened with your dog. I'd like to learn from this case. Please, can we take some tissue samples post-mortem? And bearing in mind, he'd had a negative CT. Nothing that I could find, nothing that I could treat him with made a difference. On histopathology, he had very severe interstitial fibrosis. There is no gold standard apart from lung biopsy for diagnosing interstitial fibrosis. And I don't know anyone who's doing lung biopsy in life in these patients. I don't feel like it's in their interests particularly, because even if we do diagnose interstitial fibrosis, how do you treat it?
Precise, and exactly. And again, that's where the frustration starts a little bit. We still CT them, but I agree with you. Sure. There will be some exceptions, with the classic ground glass appearance, blah 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 of interstitial.
Yeah. I think the positives are supportive.
Precisely.
But negative
feeling defects with PT. Having said that, your angio-CT protocol needs to be very good, because if there's not enough contrast in the periphery, you may find feeling defects, which are just because there is no enough contrast. So sure. I agree. We had some case of angiostrongylus or Tony Glau's head where the X-rays were quite unremarkable. And then only
so this would be class 5, wouldn't it, under the new system?
Exactly, found. So it's a bit better for interstitial lung disease, but I agree. It's not like the silver bullet, the holy grail. Yeah, we end up doing CTs in this case, but I agree with you. It's not, unfortunately, it is not always useful, or maybe most of the time it's not useful. And the problem with lung biopsies, the risks associated with lung biopsy and so on. And then my main issue is, where do you send it? Where do you send which pathology?
Who's your pathologist? Yeah, sure.
We'll look at lung biopsy. No one has experience, or very few. I don't know anyone with experience in veterinary medicine in lung pathology to look at biopsy. So that I agree. I generally do not recommend, because will it change your approach, your treatment, your prognosis? And then can we really have a reliable diagnosis? So group 3 is tough to diagnose. And group 4, maybe quickly, because of pulmonary thromboembolism. We already discussed those. So you need
I think those for me are about context, aren't they? If you've got a dog with Cushing's, or is on long-term steroids, or has a tumor, or whatever, then we'd be thinking about there's a risk of a thrombotic disorder. CT angiography, as you sort of touched on there, can be very helpful if you get the right protocol. And I've certainly seen them on either complete attenuation of a vessel or filling defects. So I've definitely seen those acute PTEs. I think with acute PTEs, like a big submassive pulmonary thromboembolism, I've seen one on echo where you saw it in the pulmonary artery sitting on top of the left atrium there. That was exceptional. Sometimes you see very severe right heart dysfunction. If they're acute, that can again increase my index of suspicion. But the chronic thromboembolic cases, which, maybe the dogs with risk factors, and very sort of insidious signs rather than very acute signs, those guys are almost impossible to image where the thrombi are, because they're all small. And they're multiple tiny thrombi rather than one large one. So they're quite unrewarding to image. Do we chase them? Yeah, we still do, because we look for a cause. And I think without a CT, we'd all feel pretty silly if later on it comes back, this dog's got a chest full of metastasis. So, sometimes we just want to see a negative CT, and then we say it's likely fibrosis given the absence of everything else, or it's likely chronic thromboembolic disease given the absence of everything else. I think that's where CT comes in for me.
Just to finalize something on echo, so then we discuss about parasitic disease, because that's a big one. So when we're talking about echo diagnosis of pulmonary hypertension, you can also look for already some causes of pulmonary hypertension on echo. We mentioned, of course, we need to look at the left heart, but of course you can look at intracardiac or extracardiac shunts, namely PDAs, VSTs, ASTs. So during your echo, especially in young patients, and then these will involve bubble studies. The other thing would be, as Kieran just mentioned, also try to open as well as possible the pulmonary artery, the right pulmonary branch, the left pulmonary branch, to see if you are lucky enough to find a thrombus there. And as we have all seen cases like these, where then you find a thrombus, a large thrombus. So echo will give us 2D findings, will allow us, hopefully, if there is TR, to calculate or have an estimation of systolic pulmonary arterial pressure. Diastolic pulmonary arterial pressure if we have PR, and then look for intracardiac, extracardiac shunts, and potentially thrombi and parasites. So if we have a patient with suspicion of duraphylariemitis, depending on where you are working and which country, of course, dogs move a lot now, and the rescue dogs are rescued for all over Europe, for example, here in the UK. So duraphylariemitis should. Pulmonary hypertension should trigger the question, travel history, should trigger the question, where is this dog coming from? And so one can already try to look at adult worms in the main pulmonary artery branches.
Have you seen that before? Have you seen adult worms in the right heart or in the pulmonary arteries?
Yes, in the pulmonary arteries, I would say rather frequently when they are positive for duraphylariae.
Yeah, sure, yeah.
So when you see worms in the main pulmonary artery without cava syndrome, of course, as you all remember, severe cases of duraphylariemitis may cause the so-called caval syndrome, where the worms are in the right heart and damage or compromise tricuspid valve apparatus, and these are associated with hemolysis, blah blah blah. So severe condition. So those guys have a clear indication to extract the worms. But then if there's just worms in the pulmonary artery, what do you do? Generally, I think the melarsomin treatment, the treatment for heartworms, is so good, and the guidelines work so well. So I think only one dog we went in the pulmonary artery to extract the worms, because generally, I don't know what's your feel. I feel like with the case we see here, if we're talking about Italy, Spain, Portugal, might be different. I think most cases, I have seen in this country, I've never seen so many worms in the pulmonary artery that we try to extract them.
And I've not seen one in a dog who has not been imported, but it is a matter of time. Yeah. Because temperatures in the south half of the UK over the last 5-6 years have been sufficient to sustain maturation of the parasite. So we used to say in the UK we didn't have temperatures. That's not the thing. We've had the vector, sandflies, mosquitoes, whatever. We've had that for millennia. That's not the issue. The issue is a reservoir. So we don't have a reservoir at the moment. We might have a reservoir one day because of imported dogs that are flying under the radar. As soon as that parasite gets into foxes in the UK, it's going to be a big problem. Yeah. So I've been saying for about 5 years, you watch this space, in 10 years, there'll be heartworm in a non-travel dog.
I told you.
Yeah. And, there's 5 years left on my deadline, and I'm still saying 10 years. So I'm trying to push my deadline out a little bit because I haven't seen one yet. But we've seen Babesia. We've seen Ehrlichia. These things have been transmitted in the UK. And when I graduated from vet school, we'd say, they're foreign diseases. You don't need to learn about those. So now, one day I'll be proven right, I think. If I keep saying it over and over, eventually I'll live long enough to be proven right. But I really think that travel history it's very important. But actually, if you've got a high suspicion, just test.
Oh, yeah, absolutely.
Because it's not that big a deal. It's not so expensive to test. Because if you don't treat them all the time or think about them all the time, you forget how to do it. The American Heartworm Society have got an amazing website with great guidelines for veterinary professionals, but also for lay people as well. And there's a website called Heartworm Toolkit. And there you put in the dog's weight and the date you want to start treatment or the date of diagnosis. And it'll tell you what to do and when. And it's great. I use that all the time for these cases. Yeah.
So heartworms, cheap to diagnose, easy to diagnose. Snap test is incredibly good, very specific, very sensitive. And Angiostrongylus. So that's an incredibly important parasite.
It's a whole can of worms. Hey, a whole can of worms.
Literally. So very important in the UK, very important in many, many countries in Europe. Slightly more difficult to diagnose, but nowadays also there is a snap test, which is not as good as the Dirofilaria one if we compare, but very easy to do and a good screening. First screening test to do in case you suspect of Angiostrongylus. Of course, you can do Barman fecal analysis. You can do fecal cytologies, which is a very quick, easy way to do it.
The fecal
and then more
smear,
advanced PCR of tracheobronchial washes and so on. So it's a highly prevalent disease in the UK, in Switzerland, Germany, Scandinavia. And so this is totally very important to consider it because it might be or is treatable.
For any American listeners out there, they'll be saying, "What are you talking about? Angiostrongylus what?"
But it's good that in their of course our ACVM guidelines, and they still describe Angiostrongylus quite a bit. Good, because it's such an important disease.
And it has been reported in the US, but mainly in kennel dogs and sort of colonies of dogs, hasn't it? My understanding is that's the sort of big risk factor in the US. I bet it's out there in the US, but no one's looking for it. But I guess the heartworm treatments prevent it, don't they? So actually, if you're
exactly, that's a good point. And
most responsible pet owners in the US are, that'll knock your Angiostrongylus out as well. So maybe that's why you don't see it.
Yeah, and just to say, important to remember, everyone, that the worms are much smaller than the Dirofilaria worms, so you don't see them on echo at all.
Absolutely.
If you don't do post-mortem, you can see them macroscopically because they're like a couple of millimeters, 5, 6, 7 millimeters, I think.
Yeah, they're small things, really. The Dirofilaria can be between 10 and 30 centimeters. I mean, they're huge things.
Exactly. And so you don't see them, but it's a really important disease to exclude. And this will be group 5 of the new classification scheme.
So I think we can understand how a huge worm like Dirofilaria immitis could cause pulmonary hypertension, because it will just physically block the vessels. It'll be hugely, we know they're antigenic. We know they'll trigger thrombus formation. What's your understanding about angiostrongylus and how that triggers pulmonary hypertension? Because I know you've done a bit of work on this and spent a bit of time thinking about this. I wonder if it's idiosyncratic.
The mechanisms will be several. So they are quite interestingly, they may cause hemorrhage or a prothrombotic state. The case that bleed do not generally have pulmonary hypertension, interestingly, anecdotically. And when we look at the lungs of dogs that died of angiostrongylus vasorum, they have severe thrombus, organized thrombus around the worms. And so these worms cause severe thrombosis. So the embolization of the worms and thrombus associated with the worms is certainly one mechanism, but they also cause diffuse parenchymal change and severe pulmonary parenchymal changes. So again, is multifactorial, but they are a nasty parasite that we don't completely understand. Again, why do they cause coagulation abnormalities in one side of the spectrum versus thrombus and pulmonary hypertension on the other? And then there is also this discrepancy that both you and me were interested at some point in time. Why would some dogs develop pulmonary hypertension and others don't? And so that's also a big debate, because there are some dogs that have nasty, severe angiostrongylus vasorum clinical signs, pulmonary signs, and do not have pulmonary hypertension, and others develop pulmonary hypertension. The pathophysiology of the parasite and the mechanism of disease is certainly very complex, and I don't think we fully understand it.
But and I do think there's variation between dogs as well. I suspect there's, in humans, they know about these PDE5 polymorphisms, which are prevalent in the population, which predict your response to things like sildenafil or calcium channel blockers in terms of treating pulmonary hypertension. I was very interested in one study. I looked at these PDE5 polymorphisms in dogs with pulmonary hypertension and a diagnosis of angiostrongylus, and compared the prevalence of those to dogs without pulmonary hypertension. And it was a small study, of course, because, we didn't see tons of them. I found nothing. There was no difference in the polymorphism distribution. Maybe it's more complex than that. I wonder if there's parasite factors, there's dog factors, and probably there's environmental factors too. So I suspect there's a lot going on with this parasite and pulmonary hypertension that we're never going to understand. Tell us about your criteria for treating pulmonary hypertension. When do you reach for the decision to treat, or rather, when do you make the decision to treat, and what's your first line drug therapy?
Those are really important questions. So it depends a lot on the mechanism. The most common cause of pulmonary hypertension is secondary to left heart disease. So left heart disease, myxomatous mitral valve disease. If we look at the large case series studies on pulmonary hypertension, mitral valve disease always up in the top. When we have pulmonary hypertension associated with mitral valve disease, we first need to treat the left heart disease. By this, I mean pulmonary hypertension in this case is caused by pulmonary venous hypertension, caused by an increased left atrial pressure. So we need to unload the left atrium. These dogs would require pimobendan, furosemide, plus minus, and RAS inhibition. And again, all aiming to decrease left atrial pressure, because by decreasing left atrial pressure, we decrease post-capillary pulmonary hypertension. So that's the very, very first step. So we need to be 100% sure that we are treating these patients' left heart failure optimally and as best as we can before reaching and touching a pulmonary artery vasodilator. So that's really important. So the most common cause, again, of pulmonary hypertension is probably mitral valve disease. We need to treat the mitral valve disease medically in this case. And why is that? Because as Kieran was saying, I think is also always a good analogy, that there will be pulmonary vasoconstriction that is protecting the capillaries. And so is in fact decreasing the amount of blood that reaches the capillaries. And now if you have a patient that is a severe left heart disease and there is some degree of pulmonary artery vasoconstriction and we give sildenafil, this may open the floodgates and overload the capillaries. So in fact, there is a real risk of pushing these dogs into left-sided congestive heart failure, into pulmonary edema. So we are always very, very careful at starting, if we ever do, sildenafil in patients with advanced left heart disease. The exception would be a patient that now has advanced left-sided heart disease, develops ascites, is collapsing, and we feel like we have optimized to the best we can left heart treatment. And this may even involve different diuretics, use one or two different diuretics, may involve stuff like amlodipine, blah, 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 just to decrease, try to unload the left atrium. And if we are confident that we have done our very best to unload the left atrium, and these patients still have severe ascites and or are collapsing, then we try sildenafil, but at low doses, we generally like to keep them in the hospital for 1 or 2 days to be sure we
Right.
don't push them into congestive heart failure.
You're more cautious than me, but I don't think that's wrong, because with these, I've never had a bad experience. I've never treated them and seen them go wrong, but I know people who have. And of course, it feels awful if you're trying to help the dog and you give them a drug and then you flood their lungs. Nobody wins in that scenario. So I think being cautious is prudent. So you use a lower dose in those heart failure patients when you think the pulmonary hypertension is part of it. What sort of dose do you go for?
My lower dose, I mean, I'm generally incredibly picky when I talk about dose with residents and so on. When people, I have to share this. When people go, 0.5, 0.6, 0.7, we have a certain tablet size.
Right.
We have a dog weight. And so is what we have.
You've got the small spaniel and the large spaniel size, Yeah,
and I avoid by all means 1/8. It's 3/4. I hate that kind of stuff.
Right.
Owner compliance is already difficult to guarantee owner compliance, and it's difficult for clients to give tablets. It's a pain.
Almost always they're on pimabendin, of course, because we're talking about mitral valve disease, plus or minus an ACE inhibitor, plus or minus spironolactone. Maybe you've layered in other diuretics as well. So then, of course, to split a tablet into 1/8, who are we kidding? They're going to get 1/8 of a tablet.
Yeah, exactly. And so sildenafil should be given TID, Q8, due to the short half-life. And so I would aim for 0.5 mg per kg. I don't go lower than 0. So the dose classically, I believe, goes from 0.5 to 2 mg per kg TID. Up to TID, right? Or TID. And so generally, I would go 0.5 mg per kg TID. So sildenafil, what I think important to take home message is sildenafil should not be our first line treatment in these dogs. We first need to optimize left heart disease treatment.
Yeah, I absolutely agree.
So, but how would you treat then other classes? How's generally your?
So let's think about the probably the next most common that I think is seen in veterinary practice, which is group 3 or class 3, that the secondary to chronic lung disease. Let's say you have a patient with a confirmed diagnosis of chronic bronchitis with a little bit of airway collapse. Maybe there's a big left atrium, but no congestive heart failure. These are patients that we see all the time, aren't they? Yeah. How do you approach those cases where they've got pulmonary hypertension and are clinical for it?
Well, I don't think that chronic bronchitis will cause pulmonary hypertension. But as you're saying, if there is bronchial collapse, there is bronchomalacia, and airway collapse, these may be associated with pulmonary hypertension. Stage B2 myxomatous mitral valve disease, as you were saying, it would be an exception where I would try furosemide in a case that I think maybe is B2.
Interesting. To drop the left atrial pressure?
Exactly, just to decrease left atrial pressure. And just not that I think they are in left-sided congestive heart failure. I'm just worried that when I start sildenafil, I would increase the left heart preload quite a bit. And
so in terms of sequence of drugs, they'd be on pimabendin because they're stage B2. So they're on pimabendin. We know that drops left atrial pressure because of invasive studies that show that it does. It increases forward flow, reduces MR severity. Then you'd say, okay, I think there's pulmonary hypertension. I'm going to start furosemide initially, or do you start sildenafil and furosemide same day?
So these are exceptions. I would generally give at least 24
tough cases,
hours,
aren't they, these ones?
24 hours of furosemide. So we start checking respiratory rates. How good are we to diagnose interstitial pulmonary edema, early pulmonary edema, and so on? So I want to be sure that these guys are dry and they're left atrial and they have no interstitial pulmonary edema and so on. So I ask the owners to check respiratory rate before starting furosemide. I do a furosemide. I start furosemide 1 or 2 days, and then I'll add sildenafil. Just you mentioned pimabendin is important to talk about that. Let's say there is no mitral valve disease or mitral valve disease B1 if you want, and now we have pulmonary fibrosis, or we have class 3 where we are convinced is clearly class 3. There is no left-sided disease. Do you give pimabendin to these dogs?
No, I don't. The number of people who say, "Oh, give pimabendin because it might help." There's data showing it might help. Well, that data was in dogs with left-sided heart disease. That they were stage B2 or C mitral valve disease. So of course they've got a big atrium, they've got high atrial pressure. When we see a dog with a normal left heart or early myxomatous mitral valve disease, stage B1, then I don't think pimabendin is going to help because pimabendin is a PDE3 inhibitor. PDE3 is not prevalent on the pulmonary vasculature. On the pulmonary vasculature, PDE5, which is where sildenafil comes in as a PDE5 inhibitor. So I don't reach for PIMO in those stage B1 dogs with pulmonary hypertension for whatever non-cardiac cause. How do you approach them? Do you give it just in case it makes a difference or not?
I would only give when they are in right-sided congestive heart failure. So
Sure,
I think there is some, exactly. So,
right.
but it affects right ventricular systolic function.
It does.
So if
it
I'm
does.
worried about right ventricular systolic function, or they are in right-sided congestive heart failure, plus minus TR. So hopefully this will also affect the tricuspid valve annulus. And so I would only in those cases I would then combine sildenafil with pimobendan.
So how about the group 1 or class 1 of the pulmonary hypertension? Within that, these are the sort of pre-capillary dogs, if you like, aren't they? So these are the pulmonary arterial hypertension cases. So therefore, it's either the left or right shunts or the primary juvenile or neonatal vascular disease. Let's forget about those guys. They're super rare. And generally, I would say try and treat with sildenafil, see what happens. The prognosis is pretty poor if they're a young dog with no shunt and bad pulmonary hypertension. Although I've seen some do fine for a little while. Let's say we've got pulmonary hypertension with a PDA or pulmonary hypertension with a VSD. What's your approach to those cases?
Yeah. So let's say we have a PDA with left to right shunt, and then we have pulmonary hypertension. Just to remind everyone, so how do we diagnose pulmonary hypertension in this case? Having a PDA, you will know the pressure gradient between the aorta and the pulmonary artery. And so you expect a normal pressure gradient, let's say in systole of 100, around 5 meters per second, a peak systolic gradient between the aorta and the pulmonary artery. So then if we are convinced that are well aligned with our PDA flow and that the pressure gradient is lower than that, one should suspect that there is pulmonary hypertension. Need to be careful with the alignment. I also like to look at the size of the right pulmonary and left pulmonary branch, especially the right pulmonary branch. But so if it is left to right, there is pulmonary hypertension, everything should be fine. Is when they are bidirectional. So we have a PDA that are bidirectional, meaning there is severe pulmonary hypertension, or when they are right to left. So just to remind everyone, when they are pure right to left, is contraindicated to occlude the ductus because the ductus is working as an escape valve. And so one should not occlude the ductus. Start treating this patient with sildenafil to try to improve pulmonary pressure. So we want to see how reactive those pulmonary arteries still are. How will they respond to a pulmonary artery vasodilator? So when they are bidirectional, we start treating them with sildenafil. And then we in those cases, we tend to be, I may have seen 2 cases, 3 cases. And so we are, in those who are aggressive with sildenafil to try to make the shunt left to right. And the RVC had a few really nice cases. Maybe you saw some of those.
Yeah, a few of them are mine. I think I've seen 5 or 6 over the years.
Okay, cool.
And probably 3 or 4 were during my residency.
Sildenafil therapy to try to make the shunt again left to right and then close them.
The success for me comes with these dogs being 12, 15 weeks old. But I think generally if you see a 1-year-old dog or a 2-year-old dog with a bidirectional PDA, I still treat them with sildenafil, but I'm not hopeful of occluding them. 12, 15-week-old dog, yeah, sure, I'm hopeful to occlude them. In a cat, all bets are off. Any age, I'll aim to occlude and just be cautious about it.
We are close to the end.
Yeah, I agree.
What I wanted you to comment on is, I think we discussed pretty much everything, would be monitoring of pulmonary hypertension treatment. So can you comment on that? How do you monitor on echo? How do you monitor your treatment efficacy?
There are some challenges in monitoring these guys. So there's pretty good data out there showing that even in the face of a good clinical response, we may not have an echocardiographic improvement or change. And I think that's because over the years and overseeing the data that's come out on research into echo estimation of pulmonary arterial pressure is that we're not very good at it. We think we're good at it, but actually the data that's out there suggests that we tend to get it wrong. We tend to have a fair degree of inaccuracy in estimating pulmonary arterial pressure, which comes back to that whole point of judging it in context. Is the animal clinical? What does the right heart look like? Don't just go on Doppler. And Doppler can actually overestimate, it can underestimate pulmonary arterial pressure compared to invasive measurements that are performed simultaneously. So therefore, this clinical improvement with an absence of echo change tells us that A, we might be inaccurate on echo, but also B, on echo, we're measuring pressure or estimating pressure. We're not measuring flow. Pulmonary vascular flow is much more important. So it may be that we actually vasodilate with sildenafil and we have an improvement in pulmonary vascular flow and therefore an improvement in clinical signs, but all of our echo estimates are load dependent, which means that if there's an increase in flow, the pressures might look higher. So actually, maybe the pressure drops, the flow increases, but our echo measurements don't change. I'm comfortable with that because ultimately what I do is I base my decision-making on clinical signs. I focus on the dog. What's the dog telling us? I get the owner to tell us about the dog's quality of life. I look for the right heart failure. Are we controlling it well? Are we not controlling it well? Look at the hepatic veins. What are the hepatic veins telling me? Are they less distended? What's the flow profile in the hepatic veins like on Doppler? And finally, I look at the TR velocity and the right heart. And if the TR velocity has reduced and the right heart looks smaller or the function looks better, then I know that in that individual dog, I can probably use those measurements to monitor. If there's no difference on the echo, but the dog is much better, I know it's pointless repeating the echo for the sake of monitoring, because that's not going to change what I do, because I'm going to look at the changes and go, or I'm going to look at the absence of change and say, well, the dog looks better or the dog looks worse. Who cares about the echo? So I will always repeat an echo. And in those dogs where I see a change on the echo, I will follow that change and use that over time, maybe every 3, 6, 12 months, depending on the case and the cause of the pulmonary hypertension. If it's a case where the echo hasn't changed, I won't focus on the echo. I will focus on the dog.
Exactly. Yeah, you said it all. The only thing I would just add is I like to look at left heart size.
Right.
So because if we
filling
precisely, because if the, especially in those cases that the left heart was quite underfilled, hopefully if we improved forward flow, if we improve right ventricular forward flow by decreasing pulmonary vascular resistance and so on, one would expect a better filled left ventricle. So I like to look at left heart size. In addition to all you said, totally agree. And left heart size also hopefully will give us a better assessment of how efficient is our forward right ventricular flow.
So I think that brings us to the end of the topic of pulmonary hypertension. We've discussed a lot of different factors related to pulmonary hypertension. Jose, what would you say the top 3 take-home messages from our discussion would be for vets out there looking at dogs with potential pulmonary hypertension?
Right. So I would think, remember that mitral valve disease is the most common, left heart disease is the most common cause of pulmonary hypertension in clinical cases. I would suspect the presence of pulmonary hypertension clinically when these dogs develop ascites or have syncopal collapse events. When treating these dogs with mitral valve disease and pulmonary hypertension, remember to first, you should optimize your left heart treatment, aiming to underload and decrease the left atrial load. Finally, think about travel history, test for parasites, because both urofilariae mites and Angiostorongia vasorum can cause severe pulmonary hypertension and may be very rewarding when you treat them, because you may resolve pulmonary hypertension in these cases. Brilliant.
I'm just going to add a top fourth message. Always tell people that sildenafil is Viagra, because otherwise they go home and Google it and think you're doing something very strange to their dog. So get ahead of that conversation.
That's a good tip. That's all for us today. Thanks for listening to another episode of the Animal Heartbeat. Please follow us on socials, our Twitter and Instagram handle @heartbeat_pod. See you later. Bye-bye.
Bye-bye.